the years, I've been the recipient of MFM referrals for placental MR after MFM ultrasound studies were either indeterminate or they wanted reassurance. And my experience with MR is that it's helpful when ultrasound is equivocal, but a negative, well-performed ultrasound really has a very high sensitivity and specificity for mitigating against increta and percreta. And I would echo the comment that accreta really is not, I believe, imaging. Imaging does not rule in or rule out accreta, patterns of accreta that do not warrant hysterectomy with sufficient statistical power. But I'm not talking about that today. I'm talking about non-adherent placental issues. And these are cases that were referred to me by MFMs for, not for placental issues, but for rule out fetal problems, unexplained growth disorders. And the use of MR, we have stumbled upon significant placental disease that was otherwise not suspected by the MFM. So we're going to be talking about some major primary patterns of extreme placental histopathology. And the reason why I believe these are important to recognize is, one, is that they are, have a significant association with all serious placenta-related adverse obstetrical outcomes. And maybe even more importantly, they are associated with end-organ fetal disease, and as we now know, severe placental disease confers increased risk, lifetime increased risk for not only maternal cardiovascular disease and metabolic syndrome, but also confers increased lifetime risk to the child for cardiovascular disease, metabolic syndrome, obesity. From a practical perspective, when we see these abnormalities on MR, send that placenta to pathology for a high-quality histopathologic evaluation. When these diseases are identified, the patient is at increased risk in their next pregnancy for recurrence. And these are probably patients that should be treated with early institution of low-dose aspirin in the next pregnancy. So there are important implications, clinical implications for identifying this disease, and the cases that I'm going to show today reflect how we stumbled upon this when the MFM was not suspecting placental disease. Next, please. There's very little good literature regarding regarding MR evaluation of placenta and its predictive values. Next. So I'm going to go through 4 case presentations now. The first case, the final pathology diagnosis, was peribilious fibrin deposition. The reason for the MFM referral at 26 weeks was echogenic bowel and a small baby with normal umbilical arterial Doppler. The MFM expectation for MR was to investigate possible fetal intestinal pathology due to the echogenic bowel. The MR was able to show that the intestines were normal. The MR found a very abnormal placenta. And the pregnancy outcome was preterm labor and delivery at 35 weeks of a 3-pound baby. The placental pathology here was a weight less than 10th percentile, 40% abruption, and massive peribilious fibrin deposition. Next. So let's go through some images now. The MR lingo that we use, there's T1, there's T2, there's diffusion weighted imaging. But this is what normal placental tissue. Could we turn down the lights a little bit, maybe? Dim the lights, please. This is a homogeneous normal T2 placenta. And on this sequence, we have this thick layer of dark tissue. And on the diffusion-weighted sequence, we see this undulating, thick, dark basal plate. And this represents dysfunctional placental tissue, fibrosis, calcification, but basically placental tissue that will be ineffective in oxygen transport. Next. So, what do we know about massive perivillus fiber deposition, also called maternal floor infarction? It's a risk factor for virtually all adverse outcomes, from miscarriage to cerebral palsy. Its recurrence risk is 50 to 75%, and many affected women never achieve successful pregnancy. So again, to summarize, this patient was sent to us by MFM for basically rule out fetal intestinal disease due to echogenic bowel, and what we end up with is a very abnormal placenta as a risk factor for preterm delivery and fetal and organ disease. Next. MR here was unique in its ability to say that the bowel was normal. MR's ability here to diagnose significant placental disease, even with normal Dopplers. A theme here throughout my talk, and the next talk I'll give this afternoon, is that umbilical artery Doppler is not enough, that you could have significant placental disease with normal umbilical artery Doppler. And also another theme here is echogenic bowel, a marker for intestinal ischemia due to placental disease. And if you come to this afternoon's talk, we'll see more examples of that. Next. Next case is, you're good, you're clear. The reason for the MFM referral here was again echogenic bowel and enlarged cavum septum pellucidum. The MFM expectation from MR was again fetal evaluation, not placental disease. We were imaging at 27 weeks a fetus that had severe IUGR, maternal hypertension, reversed umbilical arterial flow, and extremely elevated inhibin A. Again, another theme here is that look at your biochemical markers. Extreme elevations should not be ignored. And the MFM reported no abnormality with the placenta. So, next slide, please. The MR was able to demonstrate normal intestines and normal brain, and that addressed the MFM's reason for referral. And the placenta, again, was very abnormal, showing macro-hemorrhagic basal plate infarcts, huge preplacental subchorionic hematomas, which were isoechoic on ultrasound and very difficult to see. Pregnancy outcome was C-section, was 3 days after imaging, emergency C-section. The newborn was hydropic and experienced early neonatal death. The placental pathology here showed fetal thrombotic vasculopathy, villus histology consistent with maternal malperfusion, and nucleated RBCs in fetal vessels consistent with a chronic hypoxic distress. So, this is a T1 sequence. T1 sequence, the amniotic fluid is dark, and here's placenta, and this white mass here is a large hemorrhagic infarct. This is a diffusion-weighted sequence, and again, this is amniotic fluid being white. This is relatively normal-appearing placenta, and again, this thick, dark basal plate, and darkness on diffusion means lack of oxygen, means diseased placenta that will not, that will inhibit oxygen transport. The MR here, you can see the massive disproportion, the wasting of the abdominal circumference in comparison to head size. And this is placenta here, and we see this layering effect. And this represents a huge subchorionic preplacental bleed, which on ultrasound was isoechoic and very difficult to see. In the sagittal plantar section, again, these multiple large hemorrhagic infarcts along the basal plate, this layering effect of a preplacental subchorionic bleed. Because of the size of these bleeds, I wanted to know whether or not the fetus could be anemic. The MCA Dopplers were very high, over 70 centimeters per second, consistent with fetal anemia. Aortic arch had reversed diastolic flow that has a high predictive value for acidemia, and the umbilical venous tracings showed systolic pulsations. So, although the MFM referral was to evaluate for fetal disease, MR uniquely demonstrated significant placental pathology, and the post-MR targeted ultrasound showed an acidotic baby. So the pathology, what does the pathology literature say about hemorrhagic thrombotic vasculopathy? That amongst 84 perinatal autopsies, almost 20% demonstrated thrombotic vasculopathy of the placenta, and 6 of 16 autopsies demonstrated thrombi in major end organs. So again, when we see significant placental disease on MR that was really undetected on MFM ultrasound, there's a significant risk for fetal end organ pathology. Some take-home lessons from this. MR's superior ability to identify macro hemorrhagic placental lesions, abruptions, and subchorionic bleeds. And if you have a significantly small baby with normal Dopplers, consider MR to look for placental disease that can be occult on ultrasound. And I would argue that even if you have abnormal Dopplers and you know that there's got to be placental disease, consider MR to better evaluate the fetus, in particular the brain for end organ disease, and also kidneys and intestines. Next case, the final pathology diagnosis here is placental hemorrhagic endovasculitis and chronic colitis. And this was a 24-week AGA fetus with unexplained elevated maternal serum AFP. Again, returning to that theme of extreme biochemical analyte abnormalities that are unexplained, think placental disease. So again, the MFM referral was to really evaluate the fetus, to find a fetal explanation for elevated maternal serum AFP. MR of the fetus was normal, and the MR of the placenta demonstrated striking placental abnormalities on all pulse sequences, and also marginal cord insertion. Another recurrent theme is that marginal and velamentous cord insertions are part of the spectrum, the pathologic spectrum of impaired placentation, and when you see that, it's a risk factor for placental dysfunction. The pregnancy outcome here was 36 weeks of a 5-pound baby. The placental weight was less than the 3rd percentile, and the placental histopathology showed multiple abnormalities, chronic colitis, stromal fibrosis, stromal hemosiderin, and hemorrhagic endovasculitis. So normal placenta on ultrasound, seemingly homogeneous. Remember, this patient had normal Dopplers. On MR, we see this is a marginal cord insertion here, and we see on MR these multiple sort of parallel hyposignal intensities. So this is a heterogeneous, not only is this a heterogeneous pattern of signal intensity, but there's sort of an organizational component to it. Too many straight lines traversing the placenta in its entire depth. On T1, again, this is too many black holes, which could not be seen on ultrasound. And again, another view of this placenta, very striated appearance with hyposignal intense tissue. And again, when we see this dark tissue on MR, in the appropriate clinical context, we need to think of significant placental disease and dysfunction. So what does the pathology literature say about colitis of unknown etiology? It's believed to be a host versus graft response. It is a major risk factor for CNS injury and stillbirth, and it carries a significant 20 to 30% recurrence risk. So, in addition to the other clinical reasons why I think identification of severe placental disease is important, it also, from a medical legal perspective, establishes antecedent disease that is not due to any peripartum, obstetric, or neonatal management. Teaching points: consider placental MR for unexplained extreme alterations in biochemical analytes. And I would add to that uterine artery Doppler, quantitative umbilical venous Doppler, and middle cerebral artery Doppler, as well as umbilical artery Doppler. Again, don't ignore marginal velamentous cord insertions, although that can be a non-pathologic normal variant. It should be sought in all ultrasound studies, and if found, it's worthy to pull out your first trimester biochemical analytes, your quad screen analytes, look for extreme abnormalities, do uterine artery Doppler at minimum. And I think this will be the last case. This was a normal placental MR with velamentous cord insertion, but abnormal uterine artery Doppler. The reason for MFM referral was, again, unexplained elevated AFP, rule out fetal malformation. The MR demonstrated normal fetus, normal placenta, with the exception of a fundal velamentous cord insertion. The my post-MR targeted ultrasound demonstrated abnormal uterine artery Dopplers with bilateral early diastolic notching, and normal umbilical artery and normal quantitative umbilical venous Doppler. Normal pregnancy outcome here. Preterm delivery at 36 weeks due to preeclampsia and thrombocytopenia with normal community hospital placenta pathology report. This was not sent to a pathology specialist. Here is the velamentous cord insertion. This is placenta on MR. This is the velamentous cord insertion. This was abnormal uterine artery Doppler with early diastolic notching. And so what do I think are the main teaching points here? The patient was sent for unexplained elevated maternal serum AFP. And I think for any extreme biochemical analytes, uterine artery Doppler should be performed. The MFM didn't do it, and despite normal placental MR, the presence of that velamentous cord was a risk factor. We did the uterine artery Doppler, and found a significant risk factor which resulted in preterm, which was contributed or predictive of an adverse placenta-related pregnancy outcome. Unexplained extreme trendings of biochemical analytes, I believe, necessitates uterine Doppler and intensive imaging of placenta and umbilical cord insertion, and that when seen in concert, they are predictive, they increase the risk for placenta-related adverse obstetrical outcomes. So in summary, I think the MR of non-invasive, non-adherent placenta disease can detect alterations in placental morphology not seen on ultrasound. MR detection of altered placental morphology can narrow the differential diagnosis for otherwise unexplained SGA and or unexplained biochemical analytes. Whenever you have an SGA fetus that has normal chromosomes and no detectable malformations, is that SGA fetus constitutionally normal, or does it reflect placental insufficiency? And MR can help with that differential, especially if you have abnormal biochemical analytes. And I think even if the baby is SGA, it can help with determining the severity of placental insufficiency. Thank you for your attention. Any questions? I've had no I have no experience. I haven't read anything, but I think that would, a good placental histologic evaluation.
Would it do the same information?
No, it would be more. It would offer a specific diagnosis. I think the MR here alerts us to the presence of significant disease, or increases the risk for significant disease. But the final diagnosis is still in the pathologist.
Please?
Yes.
Yes, Howard Clark from Israel. But let me say how much I enjoyed your talk this morning. But can I just take you up on a couple of points, please? First of all, you mentioned at the beginning that these patients should be started on aspirin. But do you have any evidence that aspirin really makes any difference? Secondly, we see a number of these patients in the recurrent pregnancy loss clinic who come with second trimester fetal deaths, or even early third trimester fetal deaths. We find that they respond to steroids. Do you have any experience with that? And the third question is there any correlation between these findings that you've so clearly shown and antiphospholipid syndrome or even hereditary comorbidities? Thank you.
First of all, I'm a radiologist, so in terms of management, I can only quote U.S. Preventative Task Force and ACOG and the American Heart Association that states that they believe that early aspirin therapy is appropriate for for patients who've had prior pregnancies with significant placenta-related adverse obstetrical outcomes. So that's the literature that the MFMs who are referring me these cases are well aware of.
And that's expert opinion rather than evidence.
Okay, fine. Now, regarding your second question was a correlation with antiphospholipid.
Yes, or hereditary.
Yes. So most of the pathology reports that I read from these cases, depending upon the pathologist, they say correlate with a full thrombophilia workup, because there are associations between all of these pathologies and various maternal diseases. And the third question was? Steroids. Again, not I don't manage pregnancies.
Thank you. Thank you very much.
Thanks. Thank you all.
So tranexamic acid is known to reduce blood loss in patients with any type of postpartum hemorrhage. What the women trial did was randomise 110,000 women, mostly in resource-poor countries, and showed a dramatic improvement in maternal mortality. So, for example, in this particular situation, we would give tranexamic acid immediately after delivering the baby 1 gram IV, and give it 1 hour later again. I don't know what you do, but that's what we do.
Sure. Yeah, absolutely. First of all, I'm going to ask the rest of the speakers this morning to come up, and we're going to have a little panel session on placenta accreta and imaging and anything else you want to talk about. So those of you who are interested in, please stay and ask questions, and those of you who want to go eat lunch, go ahead. But we'll try to answer any questions about placenta accreta. I think this is a great treatment that's underutilized, and it may be that we ought to do it for all cesarean deliveries. And the MFMU is going to do a randomized trial. But there's some evidence that using it prophylactically at cesarean delivery can be helpful as well. And so I think there's enough evidence that if somebody's bleeding heavily, it ought to be used. And I think that it's so promising and so low cost and low risk that it may be worth using in a prophylactic fashion.
Did you want to repeat the question? There's a lady, yeah, just behind you.
We use Saturday here, as a protocol in our hospital, we use Saturday baby in the OR, and after the C-section or if we do, surgery, immediately we give transfer to Saturday.
Yeah, I think that's totally reasonable in placenta previa repeat cesareans, but it's actually not useful in this sort of higher stake setting when you're probably going to do a C-test. Because the rectal absorption of misoprostol is slow because it's not a high acidic environment. The stomach is a faster absorption site. And we're probably not going to give people a glass of water and 5 misoprostol tablets during a cesarean hysterectomy. But for placenta previa, I mean, a lot of your comments actually are very important in regard to placenta previa. People can bleed more at a placenta previa cesarean section than at an elective cesarean hysterectomy for a placenta previa, because it's such a controlled operation there. Whereas placenta previa cesarean sections can get out of control pretty quickly, can't they?
You bet. Couldn't agree more. So, do you guys have any questions?
Just a comment. There was an interesting comment just off the cuff by Dr. Keith about hematuria.
Sure.
Is hematuria something that you just automatically teach your residents to watch for when you have this kind of situation and you're following it through the pregnancy? I mean, it seems basic, but I just...
It's a cardinal symptom.
This was, I thought...
I'll give an example. I got a phone call once saying, I had this patient at placenta previa, she's having hematuria. I think I should do a cystoscope, and I said, no. Transfer her so we can help with your patient. So then she had an MRI. The other thing is that I want to commend that many of the pictures he showed, he's imaging this area with a full bladder. In the White Journal recently, there's a Delphi consensus on imaging, and it does not mention the importance of the bladder being quite full. I think it creates beautiful, clear pictures, and I just commend you on that.
The hematuria it's very specific. It's not very sensitive. Most patients don't have that, but it's very specific. And if you have that, it's terrific to have somebody who's facile with not just bladders but with ureters at your case.
Can you discuss the exclusion of methotrexate from the current protocols?
Yeah. So. The placental trophoblast necrosis quite quickly by itself, so the decay curve of HCG in blood is really pretty rapid without methotrexate. And all methotrexate does is suppress the maternal immune system and increase the infectious complications. So methotrexate is not used anymore if the placenta is out in situ after cesarean delivery. That certainly would be our case. We don't use that.
Yeah, I would triple emphasize that. It doesn't work and it's dangerous, and there have been a couple of maternal deaths related to it, so that's about as strongly as we can make it.
Well, that was going to be my same question. question, and you just talked about an interdisciplinary team, because at our institution we operate with GYN oncology. So in a recent situation with Percreta, we opted for conservative management, and oncology felt very strongly about methotrexate. So I think it just speaks to the point of really having everybody on the same page and not in these silos.
I think the key thing, it's not what somebody's board certification is, it's actually that they have an active, keen interest in moving morbidity. Because if that was the case, it's perfectly obvious that methotrexate is not a good idea. And the real issue is, why not do a CHIST in the circumstances? I think we all learn from each other. We actually have a Dropbox group. We fire all the papers into it, so it's a nice new paper like that. Nice new paper from the US in the American Journal has been in our Dropbox and shared by everybody. So.
I mean, I think that was a really great question because it illustrates the problem that we have right now. And the problem is this disease, is becoming incredibly common relative to what we saw, back in ancient times when I was a resident. But it's still not that uncommon in every center. It seems like we're doing this every day. But when we look back at the number of cases we have a year, it might be 60. And it's hard to do randomized trials when everybody's doing 50 of something a year. You can't do a trial yourself. And so every place has evolved their way of doing it. And they're totally convinced that it's correct, it's the right way, and everybody else is wrong, and everybody else is crazy. And there's no data. And I have a slide that shows, it's got two lines. One is data, and the other is passion. And the more data you have, the less passion there is, because that there's a right answer. And when there's no data, everybody's passionate. And so what we really need are randomized trials and collaborations among different groups, so we can find out what is the best surgical approach. And I thought John's comments today about the balloons are terrific. There's no question that if you use the balloons, you'll have less blood loss. And there's no question that if you use the balloons, you'll occasionally knock off a leg or a buttock. What is, should it be used in everybody? Should it be used in a certain level of risk, or should it never be used? And we're only going to find out if we actually do a study to determine that. So we're trying to develop a consortium to try to address some of these questions. And for now, the best we can do is not answer them. And things like this with methotrexate, the best we can do is try to learn from each other's mistakes.
The dad reminded me, of course, that in the early first trimester, C-section scar pregnancies, clearly methotrexate is absolutely the correct treatment because you have a lot of proliferating cytoplasmic blast cells which would be killed by that drug.
Question for Dr. I actually have a question for both Dr. Schwartz and Dr. Cohen. For Dr. Schwartz, the risk of placenta accrevia in prior cesarean sections for a posterior placenta accrevia. Does ultrasound and MRI have the same sensitivity in detecting accrevias as it is with an anterior placenta accrevia?
Well, first, ultrasound is always better, just in life. I think that each modality has its pros and its cons, and the data for non-anterior are more difficult to collect. It's just less common. But when you mentioned posterior placenta previa, I would argue that you don't need the previa part of it, because once you're not dealing with the hysterotomy, it could be anywhere in that placenta. You can have a fungal accreta, right? You can have the DNC case, the endometrial ablation case, the myomectomy cases. None of those were low anterior previas, and the presence of the previa itself is less important. So I don't want you to. So we have to be careful not to only think posteriorly. Overall, I mean, the SMFM and other committees and expert opinion will talk about MRI having some advantage over ultrasound in non-anterior previas because of penetration issues, and because ultrasound is so reliant on that acoustic window provided by the full bladder and bladder interface, whereas posteriorly you don't have that. So you can get lucky with some of the cases that I showed seeing it posteriorly, but it's much more difficult. And in my practice, and I think it's consistent with some of the guidelines, MRI is usually used for cases that you're worried about something non-anterior, and if you're worried about significant parametrial invasion and you're really trying to give the oncologists a little bit of more information and give the counseling in terms of the potential extent of the surgery that might become necessary. That's in our hands.
As a recipient of referrals from MFMs who've done ultrasound and still want more information. I think the contribution of MR is really to optimize per-creta assessment, pelvic sidewall vascular invasion, abdominal wall invasion, cervical invasion, intestinal involvement. And posteriorly, it depends upon how well you see things on ultrasound. If you have a well-performed ultrasound that shows there's low risk for increta, I think, and the contribution of MR is, I would say, minimal. But I would add that in terms of using subplacental vascularity, evaluating the subjectivity of that, is it too much or too little? I'm a hands-on sonographer, so I never accept a placental MR case unless I do my own MR, my own hands-on ultrasound thereafter. So the MR gives me a very global fundal to cervix assessment of the placenta, and it keeps me in on areas of bulging that I want more intensively studied with ultrasound. So in my hands, it's very both complementary. But in terms of Doppler, I spend a lot of time seeking high velocity, high volume arteriovenous shunting. And what I do from a very practical instrumentation perspective is I take my PRF and I just go all the way up to 80, and that will filter out all of the low velocity blood flow, and that helps me find those velocities, those high volume, low resistive velocities that are 80 to 100 to 120. And I use that to correlate with the other signs on MR and ultrasound together to try to enhance the specificity of the imaging.
So I want to make a comment, which is that MR ties its hands up its back a bit by not using gadolinium because of gadolinium instability in pregnancy. So one of the things we've actually started doing is using agitated saline. You probably use that for looking for tumours in the liver and other areas. So we've actually done a few cases where the fetus has been non-viable or had a lethal anomaly, and you can see really very rapid aberrant blood flow in the placenta using the agitated saline ultrasound method. Yeah, it's really cool and interesting. The other comment I wanted to make was that I was going to ask Nadal to comment on it, is we go back to the IPS testing values in patients with suspected procreta because they have typically quite high PAP-A values, often 3 or 4 multiples in the median. So if you don't have a twin pregnancy, a singleton, a previous cesarean section, a previous section and a high PAP-A for no good reason, that's another little clinical vignette to be aware of. I don't know if you had any experience with high PAP-A and these questions with me.
That's a part of my when patients schedule for my evaluation, that's part of our intake. We insist on getting whatever first or second trimester biochemical analytes.
Just firstly, before I forget, I need to tell you guys that there will be abstracts on the bulletin boards in the exhibit area, and the authors will be there during the breaks. So if you want to talk to anybody about abstracts, be sure to do that during the breaks. I just wanted to follow up on a couple of these comments. First of all, it may be that gadolinium is safe in pregnancy, and there's a lot of controversy about it. Most radiologists will not use gadolinium during pregnancy, and there's a fear of being sued, and there's certainly not 100% certainty that it's safe, but there's increasing evidence that it may be safe, and it's being used more and more in animals and humans. Secondly, there's something called the Human Placenta Project, which is a big NIH initiative to try to improve our ability to understand placental function during pregnancy. And one of the phases of that is to improve our ability to image the placenta, and Dodd and his group are part of that. And people are using a variety of different techniques to get better at placental imaging. Some of those studies are focused on placental function, but some of them are focused on placental blood flow and even placenta accreta, using modalities that are safe in pregnancy. And so we may get better at this, and we may find some things that we haven't heard of yet that are better. Second, when it comes to biomarkers, the holy grail of all of this is to 100% figure out whether you've got placenta accreta or not. If you could predict with 100% certainty, then you'd do a planned cesarean hysterectomy and stay out of trouble, and it would be great. But you might do a few hysterectomies you didn't have to do. And if you're 100% negative, you'd forego the hysterectomy. But then if you do that and you're not perfect, you might have a lot of bleeding and be able to avoid it. So the better we get at prediction, the better we are. Right now, imaging is very good, but it's not perfect. You know, and some combination of imaging and your clinical story gets you somewhere in the 80 to 90% range, but not 100. So all the biomarkers are good, but not great. You know, there are many proteins made by the placenta, things like PAP-A, things like HCG or AFP. And there's a correlation between whether you have an accretor or not. But none of them are good to say, you know what, the PAP-A is normal, there's no accretor. Or the PAP-A is high, there is an accretor. It's just another piece of imperfect evidence. But as we continue to study this, maybe our predictive abilities will get better.
Just to follow up on Dr. Silver's comment about modality, that have you used 3D, 4D, HD color for accretors? I saw it in China a couple of weeks ago.
So just a comment, so for the people that don't know, the HD flow or the HD color is really a power Doppler mechanism where they retain the ability to look at directionality. But the actual data being acquired by the ultrasound machine is the same data, just being manipulated a little bit different. The length of the ultrasound pulses can be a little bit different in order to retain the ability to comment on velocity and direction with less accuracy, but at least it's something. So there's a lot of people working in this KIBA, which is a radiology group looking at quantitative image bioanalytics and biomarkers, trying to find ways to really get firm, accurate, precise information. And I don't know if any of the, hopefully none of the ultrasound vendors are in the room, but a lot of these machines, we get quantitative markers from them, but what's going on behind the machine actually changes more than we know. We can play with the PRF and change the scale to change the information, but when you're changing the PRF, the machine is changing the wall motion filter too, you just don't know that. And so therefore, when you're trying to quantify, because I think the key here is moving from subjective evaluation to objective evaluation. It's not just if it looks high or low to me, it's how can I quantify it so that me and you are looking at the same picture and we'll come up with the same answer. And that's the key. So HD flow is helpful in that it still retains the sensitivity of power Doppler with a little directionality, but in my opinion, it's going to be one of those things where some people will like it, some people won't, but it will not be hindered by data. It'll be just subjective opinion if somebody likes it better. So one last comment, which again is just a general comment about the placenta. And I've learned so much as part of the Human Placental Project, and there's a conference on, I don't know if I'm supposed to sell it or not, but there's a conference next month in July down at NICHD, which is a free registration conference specifically about placenta and includes imaging and other forms of research. It's free, you can look on their site. But the placenta obviously is a passion of all of ours if we're up here, but it's because there's so little data. All of us as clinicians or sonographers are looking at the baby so much. We need to put more attention to the placenta, but we also have to retain maybe the humility or the objectivity to make sure we're doing it in a way that we think is reproducible, that is actually going to be able to be stable in other people's hands with the test characteristics that would allow us to help patients. Because like Dr. Silver said, when there's no data, we all are even more firm in our opinions. And it's the collaboration and working together in consortiums like the Human Placental Project that hopefully all these different opinions and all this different passion comes together and provides tools that will help us all.